Hello, welcome to everybody. We're about to start in 3 minutes. We will start at 12 on the dot. Okay, colleagues, this is Isabel Noguer, head of MediPIET at Instituto de Salud Carlos III in Madrid. I welcome all of you to this third MediPIET webinar with the participation of the ECDC and Dr. Pasi PENTTINEN. Beforehand, I would like to inform that this webinar will be recorded and shared on the MediPIET's website. For this reason, we will consider that anyone who will ask any question during the question and answer section agrees and gives his consent to be recorded and the video to be shared on the website. If any of you want to ask any question during the question and answer section without giving the consent to be recorded, please type your questions in the chat box and the moderator will address the questions to the professor. So this time, as I said, we have ECDC and Dr. Pasi PENTTINEN, who's the principal expert on vaccine preventable disease and immunization at the ECDC. He's coordinating the organization's work on surveillance, risk assessment, preparedness, vaccines, training, and scientific advice. During the COVID-19, he's been tasked as the technical lead for the pandemic. Dr. PENTTINEN is a medical doctor specialized in public health. He's an epidemiologist with a lot of experience of working for the public and private sectors at local, national, and international level in Finland, Sweden, and Indonesia. His current research interests include operational research in surveillance, pandemic preparedness, epidemic intelligence, and influenza. And he's learning social media monitoring at advocacy on the Twitter as at PP Pentin with double T in Twitter. Dr. Penttinen will give us his insight on COVID-19 surveillance methods. We know, Dr. Penttinen, that you are really busy with this epidemic, with this pandemic at the ECDC. For this reason, we are really honored to count on you and to have you for this webinar. You have the floor. Thank you very much for your participation. Hello, Dr. Penttinen.
Do you hear me?
Yes.
Sorry about that. I lost my the video feed myself here, so I hope that my face is more or less on the picture right now. It's truly a pleasure for me to be speaking to you here today. As you mentioned, it is really quite a hectic time at ECDC. We have been working in a crisis organization, what we call the public health event plan, since January of this year on COVID-19. And I'm very grateful to be working. We have probably about 1/3 of the experts, if not more, of the experts of ECDC completely dedicated to COVID-19. So what I'm going to speak today is really the comprehensive epidemic intelligence and surveillance work of ECDC, and try to draw some conclusions on this, both in terms of the results of the surveillance, but then also I think this audience, I myself am EPIET fellow, having come through the European program, and I know how interesting for this audience it is to try to understand also how the various kind of surveillance systems work in this kind of rapidly evolving setting. So that's what I thought I would take you through in the next half an hour. Can I just check before I start going that do you see the complete slide on your end? And if you need the talking head on the video, do you see my video suitably there?
We can see you and your slides. You can go ahead. Thank you.
Excellent. Thank you. So the challenge of working with disease like COVID-19 is very similar to the challenges as working with influenza. It means that this is a disease which has a very wide spectrum of presentations, and it can be compared to kind of an iceberg floating in the northern seas. The parts that we see very easily are the top parts of the iceberg, the deaths, pressures in the intensive care, oftentimes the hospital admissions for severe acute respiratory infections, but less so how it affects the consultations in primary care. You will have a lot of people who never end up in hospital with typical symptoms of COVID. Then for this disease also, it seems that you have quite a large proportion of people who never develop symptoms, at least in the format which are picked up in surveillance or epidemiological studies. And furthermore, there's quite a lot of people that when they develop those symptoms, they never actually go to healthcare and access healthcare. So we need different kinds of surveillance systems to manage this kind of situation. And if you take it from the top down, which is often the order of these presentations and how we are managing these situations, you need to have systems capable of monitoring in hospital or community mortality. In terms of excess mortality monitoring, you need to have systems in place to look at the pressures in ICU and understand what kind of patients end up in ICU. You would ideally system to cover all the severe acute respiratory infections in hospitals. For the primary care level, you are interested, or the most efficient way of looking at that is a sentinel GP surveillance system that we have in place for influenza. Some countries, of course, have electronic surveillance systems that can cover all the consultations in the country, but that's still quite rare. Then you have various kind of approaches which have been developed to look at the symptomatic and ill persons, like monitoring and website searches when you have those available, or you have participatory surveillance systems which cover this area. And to get a full understanding of how many you can methods that we have into three large chunks on the right hand side of the slide. What we do with epidemic intelligence often focuses on the more severe end of disease, while indicator-based surveillance takes those into account, but also covers areas which do not that's present in healthcare, but do not actually end up in too severe conditions. And for the bottom parts of the pyramid, oftentimes you need to set up specific studies to look at this. And what I'm going to go through now is in order of more or less what happened with the surveillance systems in Europe from the beginning to the end, to try to cover more or less all of these aspects of the pyramid in the next half an hour or so. So let's start with epidemic intelligence and the European early warning and response system that we put out from ECDC was on the first week of January, based on the report from the Wuhan Municipal Health Commission of this cluster of 27 pneumonia cases that we are now very familiar with, coming from that one seafood market. Following that, so this was picked up by our duty officers. We have a 24/7 duty system in ECDC where we monitor all sources of information, official and unofficial sources around the world, to be able to pick up these kind of threats to European public health. And this was deemed to be so very quickly following the initial alerts. Following that, the epidemic intelligence team set up a regular monitoring system to pick up all the reports of these cases. And this is end of January. You see that we started to have a very increasing number of cases reported, primarily from China, but you already started to see individual sort of exported cases on that. Intelligence team, much expanded now, has gone to continue this monitoring of reported cases. What they do is on a daily basis, they scour the web, pick up official websites of ministries of health, of public health authorities at the national and at the subnational level, and they put together daily and weekly reports of what we see there. On this slide, you see the reports of the situation in Europe as of 1st of May. And you see that there is overall a slightly declining trend from these reports. Now, this has proven to be a very useful exercise, and I'll show in the next few slides the global situation. The challenges with this, of course, is that first of all, we are completely dependent of what happens to be reported on the websites. Not all the countries decide to report the same kind of data on their websites. Sometimes you have different data reported on the subnational and national levels. So it's really quite laborious handiwork to get this data together. Furthermore, you can never be fully certain that the testing and sampling practices remain stable in these countries, and those will affect, as definition, will affect what is being reported from the country. So when you see a declining trend, you have to be very cautious to interpret that. It could be that the countries move towards testing only more severe cases, or they decide to report a subset of their cases in their national reports that get picked up. But you will get a very good overview of the general distribution of the disease, and here you will see that all EU countries have been reporting large numbers of cases since the beginning of the outbreak. And a similar kind of situation is visible globally. So on this slide, on the left-hand side of this slide, you see the reported cumulative numbers of cases per 100,000 population. And of course, once the outbreak has gone this far as it is right now, the cumulative number of cases becomes less important for public health measures. Remember that a large bulk of those cases would not be infectious or in hospitals anymore at this stage. Therefore, a better measure to look at the current situation is to use some kind of a shorter time frame for that. And we have used in various kind of outputs the 14-day cumulative number or the 7-day cumulative number of cases over the population. And you see that there is a slightly different picture on the map there. Currently, the hotspots of the infections seems to be shifting from Europe, where it was about a month or two ago, into North America and in specific the US. So in terms of the epidemic intelligence work, we were alerted very early on of this event due to this due system, and we alerted European Union member states on the first week of January that there is an unusual event ongoing, and have been keeping up that messaging ever since. It's a good way of rapid communication of initial cases reported in the EU, and enables us to monitor the epidemiology globally. However, you have this issue of under-ascertainment and under-reporting, which makes comparisons across countries difficult. It also makes it difficult over time if countries decide to change their systems during the period. So once it became evident that we are going to see autochthonous ECDC sets up together with the European Union member states and their public health authorities a case-based reporting system in the European surveillance system we call TESSY. I'm sure you're familiar with that. And some countries have now moved into aggregated reporting as it becomes quite challenging to keep up with the individual case-based reporting. On this, you will see the latest number of daily cases on the gray lines on the bottom of each slide, the 14-day notification rate on the red curves, and the rate of the notification rate of deaths in the blue curves for 32 EU, EEA, and countries and the UK. I'll leave this up and hanging for a moment so you can have a moment to familiarize yourself with what it looks like. I'd point out, first of all, that look at the scales on the y-axis. They are not the same. So if you take, for example, the UK in the lower right-hand corner, you see that the scale goes up to 400 per 100,000. And if you look at, say, what is easiest to pick up there, maybe Poland in the very left lower corner, you'll see that scale is only up to 15 per 100,000. So there's a large variance in the total numbers of a population that have been reported in countries. And this is mainly due to, as also for the reported cases in the EI, due to the testing practices. Countries have very different approaches to testing, how aggressively they are testing contacts and suspect acute respiratory infection or influenza-like illness cases in their countries, how effectively and aggressively they are testing contacts of these cases. So that's one part, and the other part is also how effectively they're following the case definitions that have been set up for this disease. But overall, if we focus first on the red curves, you will see that the trends are coming down in almost all EU member states as of 5th of May. So that's Monday of this, Tuesday of this week. So we can say that we have pretty peak in most countries, but please be very careful in interpreting what that means. We have passed the peak because of these unprecedented social distancing measures. It does not mean that the virus has gone anywhere. It is still circulating in the communities, but because it has less chances to transmit from person to person, we are seeing those decreasing numbers, and effectively also meaning that the R reproductive number is going under 1 in most of the countries. If you now focus on the blue curves, you will see that the number of the notification rates of deaths is still increasing in most of the countries. And that's quite natural, again, if you take into account that from the time the person is symptomatic, it takes about 2 weeks for the person to get severe symptoms and get hospitalized on average. And from the time of hospitalization, it can take over 3 to 4 weeks before the individuals are in severe enough condition to die. These are averages, and there's a wide variation of that, but it's several weeks from the peak of the cases in the community to the peak in the death rates that will happen. Now, the fact that we have case-based reporting happening in the TESSY system allows us to do some of risk factors and describe the cases that are reported and who end up in hospital. First of all, if on this slide we are showing the indicators of severity by age. If from left to right, you will see more and more severe indicators of the severity. So first of all, you have the hospitalization rates on the left-hand side. And on the B panel, you see the rate of severe hospitalizations. Let me just start off with that and notice that you see that the rates of hospitalization and severe hospitalization. By severe hospitalization, we mean essentially an indicator which is similar to ICU admissions. So patients who are in need of additional oxygen or respiratory support is the bulk of this group. You see that the rates increase by age. However, there is a drop in the very elderly groups in there, which we assume is reflecting the fact that there is a higher threshold for hospitalization or aggressive treatment very elderly in the EU EEA member states. On the middle panel there, you see the crude case fatality. So there you will see that this rises very, very rapidly after the 50-year age mark, again, which is quite natural. Here, though, you have to keep in mind that we do have, as you saw in the previous slide, we do have slightly different testing practices in EU member states. So this group contains, from some countries, mainly hospitalized cases because only those get tested, and from some countries it has a broader population base and has all cases who are suspected of COVID-19. Then if you zoom down on the hospitalized cases in the fourth panel, you see the rate of severe hospitalization, again, a proxy for ICU admission, if you like, and you see a similar picture as you saw there earlier on the left-hand side. And finally, one of the maybe more stable indicators of severity, you will see that among the hospitalized cases, the crude case fatality ratio goes very quickly up, starting already to increase in the 40 to 49-year-old age group, and going up to 40% in the over 80-year age groups. So what's clear, I think, is that we are talking about a severe disease which affects very heavily, especially the elderly, but also people in the working age groups. Now, we have not put together yet, but the next step would be to try to compare this with the expected mortality, let's say a monthly or a weekly mortality in those same age groups. And it's quite that the relative increase of mortality is actually similar across the age groups than what we see here. But unfortunately, I don't have those slides to show to you today. On this slide, I would also like to pause for a moment and talk about chronic underlying conditions. We have that data also available in TESSY. We're talking about cardiovascular disease. We are talking about cancer in the previous few years. We are talking about underlying chronic respiratory disease, immunodeficiencies, and so forth. And while it is true that they are being reported more in the hospitalized, the ICU admitted, and the fatal cases in increasing proportions, it is still unclear whether there is a huge incremental addition in terms of risk due to these risk factors if you adjust for age. It appears to be so, but that may not be so big as initially thought. But we don't have, unfortunately, that data to share with you today yet. Another peculiar feature with these cases, and here you see the age and sex distribution by severity, again, going from milder to more severe outcomes left to right here, is the age distribution. So if you look at on the red bars, you see the females. On the blue bars, you see the males depicted according to age groups. Lower to higher age groups from bottom to top. So you see that in terms of all cases, there is a reasonably balanced distribution on this slide, with the females being slightly more represented, especially in the older age groups. But then when you go to the hospitalized, you start to move into a male excess in this. And in specific, if you look at the ICU admitted proportion, you have much more males admitted to ICUs than you have females. Whereas the reported fatalities are slightly more balanced, but you still see more males affected across the elderly age, or let's say the older adult age groups. Exactly, this is, I think, is a slight mystery that would be good for you all to study in your own data sets and to try to better understand. There is a hypothesis that the ACE receptor, which is used by the virus for entry into cells, is the expression of this is linked to the X chromosome, and that might have something to do with the abundance of these receptors in males versus females, but I don't think there's any sort of clear data to support that yet. Another striking feature you can see on this slide, and that's the big variance on the hospitalization among all the reported COVID cases by member states in the EU, EE and UK. And again, we do believe that a big portion of this is due to the testing practices and whether you actually test only the more severe cases that are likely to need healthcare, or whether you have a nets that you're throwing out. It of course may have to do with the access to healthcare and the number of hospital beds available, but this is what we see, and we don't really have much evidence to direct the thoughts into one or another direction. But here we see the severe hospitalization rates and the crude case fatality rates among the all hospitalized cases. And so this is the, roughly speaking, the ICU admission rates on the left-hand side, and the case fatality rates on the right-hand side. And you still see much less variation in there, but you still see quite a bit of variation between the member states in these outcomes, and that's quite interesting, and again, definitely worthwhile considering a bit forward. Can we actually affect the outcomes in the hospital by whatever measure in the hospital is making such differences in the severe outcomes here? That would be, of course, a very, very important thing for us to understand. So in terms of case-based surveillance, most of the EU, EEA countries and UK have passed the peak of infections. Oops. Most EU, EEA countries and UK have passed the peak of infections after mid-March. Remember, this is mainly due to these extensive social distancing measures. There are differences and changes in testing strategies which challenge the interpretation. The severe outcomes increase very disproportionately with age, and the severe outcomes increase with underlying medical conditions. But are they true risk factors or proxies for age is still a matter that needs investigation. I'm hearing some disturbances on the line. Can you just make sure that you have your mute on from your sides? So that's what we can say from the case-based reporting, and as you see, we almost have to limit the understanding of the deaths to the hospital fatality. And got to compare across again the practices, but also because the deaths are being ascertained in different ways in different countries. You have countries who can cross-link their COVID diagnosis with their let's say social security system, and they can identify everyone with a positive COVID diagnosis that has died within, say, 28 days. For some other countries in the other extreme, you're limited to only detect those cases that have died in hospital. So that's one of the driving factors behind it. There's also one important distinction which is creating a lot of discussion in Europe right now, and that is whether the social services and the nursing homes are considered to be part of the healthcare services or not. And there's a lot of deaths among the elderly happening in some countries in nursing homes, and they may not have been reported through the healthcare structures thus far. Other countries are trying to change that practice as we speak. Therefore, if you want to compare the impact of deaths and mortality across countries and over time in a systematic way, the excess mortality monitoring is the best way of doing that. ECDC has been funding for a number of years a European project called European Mortality Monitoring, euromomo.eu, which collects daily numbers of cases of deaths from the death registries in 24 countries at this stage, although not for the whole country, for all of the countries. Sometimes it's cities or some parts of the country, but roughly for 24 countries in Europe. And they have developed an algorithm to model the number of deaths at any given week during the year. Most of the results are being displayed at Euromoma.eu. They have recently updated their website. I definitely recommend you to have a look at what it looks like. There's a lot of interactive, interesting data. But briefly said, several EU countries in the last few weeks have been experiencing extremely high excess mortality rates. When we talk about that in very severe influenza seasons, we might have excess mortality over a Z-score of more than 4 to maybe up to 8 in extreme situations. We are now seeing, as you see on this map, several countries reporting Z-scores of over 15 in their country. So these are weekly mortality rates which have not been seen in recent years for influenza for any other cause of death, and for many countries it's becoming, this excess is more than what all the other causes of deaths have been during that week. That excess seems to be exclusive. So the age groups over 65 years of age, and also the older working age adults. In the Euromoma, we only have the age grouping by 15 to 64 years at this stage. But here you see the comparison, and remember, these comparisons are with the social distancing measures that we have in place. So I hesitate to imagine what this would look like if we did not implement those measures in early March in most EU countries. Euromoma does not do that, but some of the member states also monitor these effects by a bit more stratification in terms of the age groups, as well as have the ability to stratify by sex. This is from the Belgian Statistics Office. And just to note that there is this interesting difference in the two orange or brown curves, where you see the orange curve is the oldest age group over 85 years of age, and the brown curve is the mortality among the 75 to 84 years of age, with females being on top and males being on bottom. And you see that there's a clear difference. The scales are different on the two curves, so there's a clear difference in the mortality between the females and the males. In this case, it's mainly driven by the increase or the higher mortality in the 85-year-old age groups. But remember, this is all-cause deaths, and the number which is not adjusted by the age group. So in fact, what we are likely seeing here, and I haven't checked that with our Belgian colleagues, but what we are likely seeing here is that in most EU countries, females tend to live a number of years older than males do. So probably in the 85+ year age group, there are much more females that are in the denominator, and therefore you see that's higher curve for the females in the very, very old age group. So in terms of excess mortality monitoring, several of our member states are observing very important excess mortality. There are real differences between the countries. The effect of timing and the comprehensiveness of measures is likely to have had an impact on that. Say for sure today. There might be some demographic differences in terms of the age structure of the countries that affect this, and there might be some effects of population density that also need to be studied and see whether they are driving those factors. I think I'm running slightly over time here, but let me just take you briefly through two other areas. And one is the ILI sentinel surveillance. So this is based on the system for influenza monitoring, where a number of GP practices report on a weekly basis the number of ILI, influenza-like illness cases they see, and how many of them have been positive for influenza. We have activated that system, which normally is only during the European winter period, to cover also the summer period, to be able to use it for COVID purposes. And as an example, I just show you the reports from, again, Belgium, where you do see that there is clear changes in the ILI reporting after the normal influenza season that has been happening. We don't see that for all of the countries. The challenge currently with this system is that because of the social distancing measures, of course, people with mild ILI symptoms do not end up in healthcare, and they cannot be sort of picked up with this system, and that distorts the interpretation of the system right now. Another approach that one could use is the participatory surveillance for influenza-like illness, and in Europe we have a network that we collaborate with called InfluenzaNet, which has daily reporting of symptoms by mobile phones from a large number of volunteers across EU countries. And that should be a bit more stable indicator to look at that, and you're able to also estimate the healthcare seeking behavior from those questionnaires, as you know, whether people have had symptoms and whether they actually did go to a GP or emergency room with their symptoms. So you could potentially adjust these ILI results with the results from the InfluenzaNet. And just to leave you maybe with this colorful picture, so European public health agencies and laboratories have been, I think, leading the way in terms of sequencing of COVID-19 samples. And this is a completely new world for surveillance, which creates quite interesting opportunities. There have been more than 4,000 sequences from Europe alone, the global influenza sequence database. And you have some other collaborators like the nextstrain.org, where this screenshot is pasted, that are doing extensive analysis of the sequences at this stage. We do that also at ECDC, and you can get interesting insights into the transmission chains and the sort of international distribution of the strains. And this, of course, becomes very important to monitor also changes in severity, whether there are mutations. This is an RNA virus we talk about, so it will be changing continuously the genetic makeup of the virus in terms of mutation and drift. And we need to be watching that we don't have important changes happening on that side. It will also be important for the future development of vaccines, that we know exactly which strains and which antigenic variants are circulating the globe, so that we can target the correct virus with the vaccines. Sorry, I had a comment on the Sero-epidemiology study. So as mentioned, to estimate the full number of infected individuals on any community, it is very important to look at serologic surveys or sero-epidemiological studies, and a number of countries and locations have started doing that. By the end of March, the seropositivity from these studies in Europe was, in most settings, around the range of 2 to 3%. But keeping in mind that with a very low with a very low prevalence expected, these seropositivity of the samples is likely to be quite a big overestimate of the true seroconversion rates in the population. So it doesn't say that if you see a figure of 3.2 in this slide, that you have 3.2% of the population infected with the virus by end of March. It's likely to be less than that. So what we can say from this is that there's very low levels of immunity still to be expected in most European settings. I think I have pretty much covered all of my conclusions as we've gone through there, so I won't repeat it for you. You will have access to the slides going forward. What we are planning to do next is to strengthen the SARI surveillance for severe acute respiratory infections, so hospital-based surveillance, improve the harmonization of the death definitions. We are moving into a situation where we need to use the surveillance data for monitoring the impact of lifting or shifting of the social distancing measures. We need to facilitate and engage in more sero-epidemiological studies to understand the immunity in the population and the duration of immunity. And we need to start preparing for vaccination programs and adjust the surveillance systems for that, including having a platform for vaccine effectiveness and safety monitoring in place. I'm sorry I had to rush through a little bit the end of this, but I think I've overdone my time there. I'd just like to thank once more the big team of my colleagues at ECDC who are working on the surveillance, the laboratory, the preparedness, the response, the scientific evidence aspects of this under the COVID PHE team, and the whole presentation is based on a collaborative work of the larger ECDC team. Thank you so much for your time, and if we have time, I'm happy.
Okay, thank you, Dr. Penttinen, for such a comprehensive and clear presentation. I'm waiting for a question and answer. If anyone wants to address you a question. Okay, so while waiting for question, I would like to address you a question. What are testing policies has been different across European countries. So how do you plan to assess the real dimension of the COVID epidemic in Europe?
So in this kind of situation, you have to take the totality of the information as I've just gone through. We have done also surveys with the member states, which I didn't get into, to get a clear understanding of their current testing policies and when they have changed them, so that we can take that into account. And I think future work, we have a modeling team also, which is working on various models based on the surveillance data and other available information to have a sort of slightly forward-looking forecast, but then also to be able to retrospectively assess the impacts of the social distancing measures and other measures on the epidemic.
Dr. Penttinen, maybe since there are no live questions, I can go into some questions we had in the chat. So one question is, we have a couple of questions regarding sero-epidemiological studies. And one is, what kind of antibody test do you recommend for sero-epidemiological studies? Specifically, which brand of test or company is the best according to your experience?
I'm not a core expert on that. We have a microbiology team focusing on that side. What we can say is that there are very few tests so far which have been properly validated with large sample sizes. But there are a couple coming out right now, just in the last few days, where we have seen the validation. Sort of keeping an eye on that and reporting publicly on our views on this in our risk assessments and otherwise. There is also a WHO-funded site called, I think, FindDX, where they are collecting all the various tests, including antibody tests, into one database, and will be keeping tab of the validation results on that website. I suggest to go to that website and monitor the outputs there.
Thank you for your response. Isabel, is there anybody else who wants to have a live question?
I would like to make a question, if I may. Thank you. I'm Alicia Padron from the Instituto de Salud Carlos III. Thank you very much for your conference. Has been very wonderful. One question that is when it comes to the de-escalation measurements of social isolation. Do you have any objective indicators that could be of objective guidance for the governments to initiate the processes of the de-escalation on the social isolation? Thank you very much.
Yes, we have done some thinking on that, and I actually have a few slides in the backup slides here, but they are quite comprehensive and detailed, so it may be better if you pull up on our websites the last rapid risk assessment, the 9th version of the rapid risk assessment. That contains a table, I don't think it's an annex, but a table in the text which describes potential indicators to be used to monitor the de-escalation of the measures. It's quite comprehensive, including the kind of indicators I've gone through now, but also including things like what you can do in workplaces and schools and so forth.
Thank you very much.
Maybe I can go into the next question coming from the chat. What was the proportion of PCR positive persons who did not develop antibodies? Does it influence the validity of seroprevalence studies?
Was the proportion of PCR positive cases that did not develop antibodies was the question.
Exactly.
That I don't on the top of my head. No, on this slide you have in the two bold columns. First of all, you have the cumulative incidence of the reported PCR positive cases by the date of serologic study, and you see that the ranges are from, let's say, 40 to 50,000 population to up to 300 per 100,000 population in one specific outbreak site. And that should be comparable roughly with the proportion of antibody positive samples, which are in the % range. So you see that we have quite a small proportion of the infected individual, likely infected individuals in those settings that have been picked up with PCR in normal surveillance practices. This is not the sort of comprehensive population PCR testing, but through normal case definitions and surveillance. There are two data sets which might be useful to look at for that question. One is there is a study which I think is now published from one municipality in Italy, VO with the accent on the O, where they did comprehensive PCR testing repeatedly in the population. And similarly, the authorities in Iceland have done very, very extensive PCR testing in the whole population. So from those data sets, one might be able to infer something in response to that question.
Thank you, Dr. Penttinen. Another question is there any recommendation on integrating testing of SARS-CoV into the existing national SARI and EARLY surveillance systems?
Yes, so in our forward-looking surveillance strategy, that is the proposal, that we will use the two systems. The fact of the matter is that in the EU EEA countries, SARI surveillance has not been a very strong part of the influenza surveillance thus far. We have been developing rather a very specific approach, and that is monitoring the the influenza positive cases in the ICUs, but the proposal is that countries would go for a more comprehensive SARI surveillance with testing of those cases in all wards of the hospitals, if not all hospitals in the country, but at least a representative subset of sentinel hospitals, and that there would be testing from the ILI samples, both for influenza and COVID. For next season, it's going to be very, very important.
Thank you. We have another question in the chat, and it's about the Sweden, the case of Sweden. The question is it really a success?
Working for a European Union agency based in Sweden, it's very difficult for me to go into detailed commentary about one country's public health actions or not. But let me say a few words. We can note that despite all the media coverage, the approach that Sweden has taken is a little bit more lenient in terms of the legislative and the mandatory public health actions. But if you look at all the indicators we have in terms of mobility of individuals in the population, there has still been major impacts in the mobility of the population. So I think it's fair to say that even though Sweden did not take as hard mandatory approach to these measures, the population of Sweden has been following quite stringent social distancing throughout this time. That's one aspect to say on this. The other approach, what our Swedish colleagues are highlighting, that of course the question right now is, as you see, for most of the EU member states, we have been able to press down the numbers of new cases quite significantly, but the virus has not disappeared anywhere. So what happens now is the question, and the approach that the Swedish public health authorities have taken is that they do not believe that these harsh social distancing measures can be kept up for the next 2 or 3 years, which is likely to be needed for the development of the vaccine to be available. Therefore, during that time, there will be significant levels of population immunity developing anyway. And this is the dilemma. I think the true answer to the question of what kind of approach is most effective, we will only see afterwards, at the point when either we've been able to completely suppress the transmission of this virus, or we have a vaccine available and we can do retrospective analysis across the countries.
Thank you very much, Dr. Penttinen. We have a few more questions. I'm not sure if you have some time to continue with the questions.
I have maximum 5 minutes time, so I'm happy to take 1 or 2 more.
Okay, then maybe 1 or 2 more questions. So for some countries, the policy of lockdown is discussed to be changing soon. Are we going to expect an increase of the outbreak curve again if normal daily life returns back?
That's the big question, and that's why we propose that there should be extremely careful monitoring of a number of indicators, including these surveillance indicators, as countries start to ease the lockdown. The easing of the measures, I don't actually like the word lockdown because it doesn't really describe anything very, very precisely, but the easing of these social and physical distancing measures needs to happen gradually with continuous monitoring on the indicators, and it needs to happen in a situation where we have sufficient healthcare and public health capacity to detect a large portion of the cases, isolate them, and implement strict quarantine across all the contacts. The challenge is, of course, that the impact of the measures, we will only see 2 weeks from the changes in those measures, as it takes time in terms of incubation time and presentation of the cases into health before we know what the impact will be.
Thank you. And maybe a last question. Is there any comparison between the COVID cases in different countries in their epidemic curves, taking into account the control measures in place in each of these countries?
So we have presented in our rapid risk assessment, the 9th and the 8th updates of rapid risk assessment. We have presented these results and also for all the countries the measures that they have taken and when they were put in place. We are monitoring those measures continuously, and as they start to be lifted, we hope to be able to do sort of better comparisons on that. We are not quite yet in terms of in terms of the quality of the data to be able to say anything definitive about the impact of the measures at this stage.
Thank you very much, Dr. Penttinen. I will not continue. We have a few more questions, but I wouldn't want to take any more of your time. So maybe Isabel.
Yes, thank you, Ido, for your help. Now I would like to give the floor to Dr. Carmen Varela, who's also ECDC, is also involved in MediPIET. They have the scientific leadership of MediPIET. And I would like to give the floor to Dr. Carmen Varela, our counterpart in ECDC. Hello, Carmen.
Hello, can you hear me?
Yes.
Okay, thank you, Isabel. Thank you very much for this opportunity. So I would only like to congratulate you, the MediPIET team in the Instituto de Salud Carlos III, for this initiative of organizing the webinar series, and to thank my colleague, Dr. Pasi PENTTINEN, for this inspiring and informative presentation on this data already available from the surveillance of COVID-19 in Europe. So, of course, it's important to acknowledge the support that we are receiving from the European Commission, from DG DEFCO, DG Sante, and the Joint Research Center. But let me only spend a moment to reflect on the importance of this activity, because, of course, the Mediterranean and the Black Sea Field Epidemiology Training Program and network, MediPIET, has an essential role in the preparedness and response to COVID-19. And I'm really glad to see that most alumni and fellows are contributing to this effort in different areas. I have read your survey, and I can identify areas like surveillance, early detection, case investigation, contact tracing, but not only in this field epidemiology or scientific aspect, but also on risk management and coordination. I believe this is instrumental for the network. So during a pandemic, and even more in this case like COVID-19, that is a new disease, the exchange of experience and knowledge among epidemiologists of different countries is critical. That's why, besides the work that fellows are conducting in each country, I believe that it's really important that you keep nurturing the network by this type of activities, by these webinar series or similar exchange in public health knowledge and methodologies, as I believe that this is a key pillar of the network and of the success of the program. So I would only like to thank you for this opportunity. I know that some of our colleagues in the EPIET and in the UFEM network have also joined this webinar today, and thank you for the openness, and looking forward to new webinars. Thank you.
Thank you very much, Carmen. Thank you, Dr. Penttinen. We really thank you for your time because we know you're really busy. Thank you very much to all, and see you in the next webinar. Bye.